Good evening, everyone, and welcome to the IPC COVID-19 What Now webinar. Just going to give a minute or so for everyone to jump in. We've got over 300 participants this evening, so just let everyone get into the webinar and then we'll get started. All right, looks like we've got lots of people in now, so we might make a start. So welcome everyone to this evening's COVID-19 What Now presentation. This service, or the IPC service, has been established by Murray PHN on behalf of the 6 Victorian primary health networks with funding from the Victorian Department of Health. So just before we start this evening, we would like to acknowledge the traditional owners of the country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them, their cultures, and to the elders past, present and emerging, and any Aboriginal or Torres Strait Islander people that may be joining us this evening. So what have we got on tonight's webinar? Tonight we have a large number of presenters with us, which is fantastic. So my name's Sarah Drew. I'm the Nurse Programs Manager here at APNA, and I'm also the Program Manager for the Infection Prevention and Control Helpline. I'm joined, like I say, by a number of people tonight. Our first presenter is Associate Professor Deb Friedman, who is the Deputy Chief Health Officer at the Victorian Department of Health. And Deb will be giving us an update on pretty much COVID-19, what now? We're then going to launch this evening the Infection Prevention and Control Risk Matrix. And so we'll take you through that and give you a little bit of information on that after Deb has given us a presentation. We're then going to go into a couple of case studies with a number of astute people joining us on a panel. So we have Megan Reilly and Margaret Jennings, who are subject matter experts as part of the Infection Prevention Helpline. We have Dr. Philip Webster, who is a GP in the Murray PHN region. We have Janice, who is our Office Manager for the Infection Prevention and Control Program. And then we have Lisa Sinkins, who I'm sure a large number of you have already spoken to, who is our Project Officer at the Infection Prevention Helpline. We'll then have time for some Q&As and a few closing messages and get you out of here by 7:30 this evening. So we will be using the Q&A function in Zoom this evening. So please make sure that you're not using the chat. But if you do have any questions for either Deb or for any of the presenters this evening, that you pop it into the Q&A. There is the ability to upvote. So if you see a question that you would love an answer to, please upvote it, because we will be taking them sort of from the top down. Tonight's intent is that we will be focusing on very much those sort of generic questions around COVID-19 and where to from here. If you actually have any individual questions in relation to your organisation, please feel free to reach out to us at the Infection Prevention Helpline, and we're more than willing to support and address those as we go through. But for now, I'm going to start this evening by handing over to Deb. And Deb's going to give us, like I said, a nice update on business continuity during the pandemic and interpreting guidelines. So thank you, Deb. Over to you.
Thanks very much, Sarah. I hope everyone can hear me okay. As Sarah said, I'm one of the Deputy Chief Health Officers, but my job prior to that is I'm an infectious diseases specialist, and my background, apart from clinical practice, is in infection control. And before I took over this role, I was the head of the infection prevention team at the Victorian Department of Health. So I sort of speak the same language as you all do. Move on to the next slide, please. I too acknowledge the traditional owners of the land on which we're meeting today. Next slide, please. So you may very well have seen the primary care contact management exposure event risk matrix, which sort of designates colours to tell you how high risk a contact is in the sort of primary care setting. So I guess what I just wanted to alert people to who are unfamiliar with this is that you look at the type of PPE that's worn on the left-hand side, and from the top being either no PPE at all to the bottom being full Tier 3 PPE. Tier 3 PPE being an N95 respirator, eye protection, a gown and gloves. And you can see the basic thing that you can tell from looking at this is that if you're wearing an N95 respirator, even a higher risk scenario, which is direct contact with someone who's infectious, more than 15 minutes face-to-face contact, would still be a low risk consultation if you're wearing an N95 respirator. Now, we very much understand that N95 respirators are not the most comfortable thing to wear, and we also recognise that there's not an infinite supply of N95 respirators, but that just indicates what amazing control they provide in terms of to the wearer, and also if the case we're wearing an N95 respirator, they provide incredible source control as well. I'll move on to the next slide, please. And you can see here that this designates what the implications are of being a high risk contact. So if you look at the red, it basically indicates that if you're a high risk contact within the primary care setting, for example, you'd need to have a PCR quarantine until you had the results of that test. And then you would need to have either rapid antigen tests on return to work. Potentially that could be replaced by some PCRs in the first 7 days after return to work. And we also always indicate that you could consider furloughing somebody from work depending on how high risk the scenario was. And that could be at the discretion of potentially the practice itself. The next slide, please. So I just alert you to the trajectory of cases in Victoria. You can see the peak. So it was in late September and early October that we were at our peak, but we haven't been below 1,000 cases except for a day here or there. And the first time that we went to about 1,000 cases was approximately September 28th. So we've been up there for over 2 months, and you can see that we just continue to drag on at about that same number, somewhere between 1,000 and 1,200. So this very large outbreak in Victoria is certainly not over. What we know is that in some local government areas, the pandemic is extremely active. So some local government areas such as Hume and Melton have got over 400 active cases per 100,000 population, which is extremely high by any measure that you use. In contrast to that, even some areas that previously had had no COVID infection now have, up to 100 active cases per 100,000 population. I'll move to the next slide, please. Thank you. So I wanted to just show you a little bit about what modelling suggests. This is some modelling that was done by both the Burnett and the Doherty, and you can see that the different coloured lines in the graph refer to the different types of loosening of restrictions. And if you look at the top line in both graphs, it's a red line, and that tells you that pubs and bars are open. The lines below that are the green and purple lines, which are working from home stopping, which means more people going into the offices and then holding large events. And then just underneath that is the orange line, which is cafes and restaurants opening. And you can see that all of those things, the modelling suggests, will lead to an increase in cases. And in fact, that probably is the explanation for why, despite having over 90% of the population fully vaccinated, we're still at a pretty high level of cases. Next slide, please. You can see here, this was also modelling that looked at the number of new diagnoses per day and also what would happen with hospitalisations, ICU demand and cumulative deaths. And you can see here, if you look at the top left, new diagnoses per day, they have predicted that between December and January, there would be another peak. We're sort of waiting to see whether that's going to flesh out. Potentially this could have been wrong, and perhaps we'd just have one sustained high level of sort of 1,000 to 1,200 cases a day. But we could well have a peak that's significantly higher than where we are now in December, January. And modelling gets updated all the time. We're expecting another lot of modelling this weekend, which may well change things slightly, but you can see that if that is in fact the case, that we have another peak, then that's going to be followed by hospitalisations increasing as well as ICU demand. And in terms of deaths, Victoria overall for the entire pandemic to date has had nearly 1,400 deaths. Now, that is a large number of deaths, and anybody who listens to the news can sometimes hear days where we've got 5 deaths, 10 deaths or more deaths. So this is significant. However, just making note of the death rate in Australia being pretty much one of the lowest in the world. So we have got less deaths than what would have otherwise been anticipated based on the pandemic. The next slide, please. And then the other thing about modelling shows you what to expect in terms of deaths depending on what stage of the easing plan we were up to. And you can see that it was projected that we'd have 1,200 or 1,300 deaths as we opened up. And in fact, we're sort of tracking very close to that. As I said, we're at 1,390. You can see that what that indicates is the modelling has actually been reasonably accurate to date. Modelling is not everything, but so far it has been reasonably accurate. Next slide, please. So I guess just to bring up a couple of scenarios, and I know you're going to talk about case studies later, but if you had a person who came in with what we would consider very typical symptoms of COVID-19, fever, cough, sore throat, shortness of breath, muscle soreness, nausea, I guess from an infectious diseases perspective, the best recommendation would be to instruct a patient that they need to go and get tested. And if they're feeling very short of breath, they need to go to a hospital emergency department. But beyond that, if they have already been tested, we'd still recommend, obviously, the highest level of PPE for a consultation with this type of patient. Next slide, please. And I guess just to indicate, there have been numerous times during this most recent wave of COVID-19 when GPs have been, I guess, taken aback by somebody who presented predominantly with headache, or people that presented predominantly with diarrhea. And we've had multiple cases of GP practices all being closed because a case that presented with diarrhea was found to have COVID-19, or a case who presented with headache ended up having COVID-19. So it just indicates that a lot of these symptoms are not necessarily the typical respiratory symptoms, and that getting the patient to have a test is the most important first step. And if they're very unwell from their diarrhea and they're dehydrated, then they need to be hospitalised. Next slide, please. So just a quick mention of Omicron, because it's sort of been the newest thing that we've been talking about for the last week and a half. So you're probably aware, as of sort of a couple of days ago, there have been nearly 1,000 cases confirmed globally, and that's in over 45 countries. And literally every day we're finding out about another country. First of all, there were Southern African countries. Now we know there's other countries in Africa, multiple European countries, including the UK, which has nearly 300 cases, Canada, India, the US. There's cases in India, and there's also some cases in South Korea as well. What we're waiting for is a better understanding of both the severity of illness and whether or not the vaccine is as effective with the Omicron variant. We're expecting to get that information in the next couple of weeks, and that's the whole reason for any additional measures that have been put into place right now. It's so that we can bide time while we find out what the implications are of the Omicron variant. Everybody is hoping that it will be very that the vaccine will still be found to be very effective against the Omicron variant. That's what we're all hoping for, and we're hoping that even if it doesn't protect as well from becoming infected, that it will still continue to be extremely effective at preventing severe disease. And that's certainly what we're hopeful for, and I expect that we will have more information in the next few weeks on that. Next slide, please. So this is, I guess, a graphic representation of where we're coming from and where we're going to. Obviously, we started off certainly in 2000, having a really frightening second wave with no vaccination, and we've moved to a very high rate of vaccination. We had so many reactive lockdowns, certainly within Victoria, but every state in Australia has had lockdowns. And the aim was always chasing COVID zero, but it's been many months that we have already been very clear that our goal is suppression rather than elimination. And this then led us to the roadmap for opening up and living safely with COVID. We had many, obviously, government-directed rules and restrictions, but we're moving towards, instead of the Department of Health directing everything, it being led more by the community, which I'll elaborate on in a moment. There's obviously been new pandemic legislation that's been passed, which will come into effect on the 15th of December, which means that the power does no longer sit with my boss, the Chief Health Officer, and we want to empower the community in terms of education with public health. Next slide, please. So I put this up because this is a slide that we first created in September when we were looking at the phases of our opening up and where we were heading with vaccination. At the time that we developed this slide, I think, you know, we were only sitting at about 40% vaccinated when we put this together. So we've worked through all of those targets, and I think once we hit the ground running and the trajectory really, you know, ramped up, we've been able to achieve a really, really impressive vaccination target. And we moved past all of these phases of 70%, 80%, and then 90%. We've looked all the way along at some of our different metrics, which are really important. We've looked at the R0 or the RF, which is the effective reproductive number. And we know that if it's above 1, that means that cases continue to increase. We know that if it's below 1, you stabilise or your cases decrease. And what we know most recently, our REF is still sitting just above 1, which is an explanation for why our cases are not dropping. We know more recently, a few weeks ago in New South Wales, their REF was below 1, which was an explanation why they'd had sort of stable and low case numbers. Vaccination rate, we've obviously exceeded all forecasts and I think it's 94% first dose and above 91% second dose. COVID patients in hospital, we had been tracking along, and we have a sort of scale that sort of tells us how much risk there is, and we're sort of low down on that scale right now. We know that we have adequate capacity in the hospitals. There certainly have been times during this most recent wave where we've had significant pressure on the hospitals, but we've still been able to have adequate ICU beds. And we've our rough figure of 600 ICU patients would be our sort of figure that would mean that we're in significant trouble, but we've not reached that, which is very fortunate. Next slide, please. And then, as anyone who's watched the news from October onwards, as soon as kids went back to school, there's just been a sharp rise in outbreaks in schools and early childhood. And everybody who's been working in medicine or public health has been dealing a lot with cases in schools and early learning centres. And what we know, previously it was thought that children either don't get COVID much or they don't transmit it much, and neither of those are true. So we know that kids can transmit really effectively. And when the children, whether it's from an early learning centre or from school, bring it into the household, it can then spread throughout the household and then into mum and dad's work and to the grandparents. So it's not insignificant. Next slide, please. And so this has all culminated in where we came to at the 90% fully vaccinated mark, which was in about the 3rd week of November, which is really a devolution of the Victorian contact tracing system with sort of high vaccination rates in place, meaning that we're focusing on the areas that have the greatest impact. And those include households where we know spread is really, really common, more than 50% chance of becoming infected in the same household. Friends and close contacts are spread effectively through gatherings and parties. Workplaces where people work in close confines are an efficient way to spread infection. And then, of course, schools and early learning centres. And so our focus has to be on these. And so in keeping with that, there have been things that we've asked Victorians to do, which we didn't ask them to do before, we did it for them. So we asked them to tell their social contacts. So the health department no longer calls up a person's contacts. we expect the person to do that themselves. And so the case tells their friends and the people that they have seen while they've been infectious that they've tested positive, and recommends that they get a test and stay home until they get a negative result. We ask them also to tell their workplaces or their schools, their children's schools, or early learning centres. And then those workplaces or businesses have an important role in managing the risk. The positive case tells their employer, or it tells the school early learning centre, and then either that educational facility or workplace needs to go ahead and manage it in that setting. And the Department of Health becomes involved if this becomes an outbreak, especially in a high risk setting. Next slide, please. But where we're heading towards in January, after going through these milestones, is vaccination of children under the age of 12. What we know about vaccinating children under the age of 12 is that in line with what I said before, it significantly reduces spread of infection into households and back out into the community. It'll reduce infections by up to 2/3, which is really impressive. It'll reduce hospitalisations by 60%. And that's not because the kids contribute a lot to the hospitalisations, but it's because their parents do. And it'll also reduce COVID-related deaths by more than 50%. All of those are significant gains. And the other thing that we know is because we have 94%, or what we'll end up with once we get second doses into everybody above the age of 12 years, we should have approximately 94% of everybody above the age of 12 vaccinated. If we then add in under 12s and we vaccinate, 2/3 of them, we are very close to heading towards herd immunity. Now, of course, we can't tell what proportion of under 12s will end up being vaccinated, because it's obviously going to be completely determined by parental consent, but we could well be in a situation of having herd immunity, and that's a fairly unusual thing globally. Next slide, please. And so I guess in finishing up, severe COVID-19 is really going to be, and certainly is now, a disease of the unvaccinated. I just looked up before some of the figures of patients in intensive care. And if we look at patients in intensive care, of those people who are 18 to 29 years old in intensive care, 100% of them are unvaccinated. And if you look at the people 40 to 49 years of age, 100% are unvaccinated that are in intensive care, and even 50 to 59, 75% of them are unvaccinated. We know that the DVR check-in, so the check-in on your phone that you do, that will trigger automated SMSs to possible contacts in a social sort of public setting. We ask community leaders and local councils to play a key role in their areas and their communities, and that means supporting families that are isolating or quarantining. We know that communities can promote vaccination and testing, and they can promote those COVID-safe behaviours. And my sort of final word to everybody is that even in a heavily vaccinated population, testing of people either with symptoms or people who are contacts of a case, and other public health measures such as wearing a mask and physical distancing all continue to apply. And so although many people would like to say that we won't be needing masks and we don't need to worry about these measures, it's absolutely untrue. These public health and social measures will be with us for a while to come, and we need to get used to them as part of our day-to-day lives. So I don't think I have any more slides after that one yet. That's just showing you, which I think you might be aware of, there's an area of the Victorian Department of Health website that has infection prevention resources on it for people's information. I'm happy to take any questions. Thank you. And I'm looking.
Thank you so much for that, Deb. That was fantastic. We do have a number of questions coming in now, so I might just start with some of those if you're happy to do that.
Yeah.
So the first question is regarding N95 masks, and the attendees wondering whether wearing one that is fit tested or not? So if it's not being fit tested, is it still considered low risk if they're wearing one of these masks?
Yeah, thanks very much. So as most people who've been involved in infection prevention would know, up until the pandemic, we didn't really do fit testing, certainly not in Victoria. And it was something that we sort of, gradually moved towards. There are a variety of different schools of thought about fit testing and whether or not it's absolutely required. So the answer that I usually give to this is that fit checking is the most important thing, where you check every time that you put an N95 on that you don't have any leaks, and that you do the fit checking appropriately. Fit testing is an added bonus, and for people who'll be wearing N95 respirators a lot, they ultimately should get fit tested, but fit checking every time you put one on is by far and away the most important thing. I can see that there's a question about whether or not we should test people outside. Are you happy that I just continue on with these,
definitely.
Sarah?
Thank you.
So as everybody's probably aware, outside's always lower risk than inside, where you've got some natural ventilation. And if conditions permit, outdoor is always safer. That's the reason for a lot of drive-through testing sites where it is the lowest risk. So if at all possible, that's always going to be safe. The utilisation of monoclonal antibodies. So within the hospitals right now, the monoclonal antibody that we're using, so I guess there's two that we use. So one is sotrovimab, which we use. It's for people in the first 5 days of illness to prevent deterioration and to prevent them being admitted to hospital, and it's for people who are unvaccinated. We're using quite a lot of sotrovimab, and the supply is held centrally at the Alfred, but all areas of the state can access it, and we always, even regional hospitals can request at least a small supply to be held of sotrovimab, so that they've got that. So it's not for people in hospital, it's to prevent hospitalisation. The other monoclonal antibody to mention is baricitinib, and we use that for people who have deteriorated, who have an oxygen requirement in hospital. And there's been a study that showed that baricitinib, in addition to dexamethasone, improved patients' outcomes in COVID. So those are the two that we're using. And certainly we have adequate supply right now of both those, and they should be available. But if you're in a regional centre, you can inquire, you can get your pharmacist to speak to the Alfred Hospital and determine whether or not you can get at least a smallish supply of sotrovimab to tide you over. And it says, I can see another question, do we need to test patients who present with headache or other symptoms without respiratory symptoms? Unfortunately, during a pandemic, you do. So at the beginning of this, we said respiratory symptoms, test them. We know a lot more about it now. And even previously, we used to say, if you're in an area that doesn't normally have COVID, it's probably low risk. Well, we're seeing cases of COVID in every corner of the state. So the answer to that is, unfortunately, they do need to be tested. Vaccination for children under 12 at this point is not intended to be mandatory. That would, that's not what I've heard so far, and so I'm certainly not aware of that. There might be annual boosters required, and we're not entirely sure. That's what Carol asked. As you're aware with flu, annually they change the vaccine and they change those proteins on the outside based on whatever strains are circulating. That may well be where we're heading, so that as we have new strains, you might have a new vaccine for the Omicron variant for 2022. We're going to find out a lot more about that. What we have heard from both Moderna and Pfizer is that they are less than 90 days away from having a vaccine that would target the Omicron variant if required. So if we find that the current vaccine is not going to give good protection, we would have something available in 2022. Carol's also asked about PPE for pap smears. Yeah, interesting question, because I guess you're reasonably close to a patient, but not next to sort of their mouth. If they have no symptoms nor risk factors for COVID and they're vaccinated, I think that you could wear a surgical mask and eye protection, and obviously anything that you normally wear in terms of gloves, etc. Yeah, so I guess I might just finish up on these last two questions. So What part does immunity from having COVID play? That's a really important question. Thank you for asking it, Jodie, because I actually did want to touch on this. Natural infection, unlike measles and chickenpox, where you say, I've had chickenpox, fantastic, I'm never going to get it again. That's not the same for COVID, and it's not the same for flu either, as everybody would know. So we know that reinfection is really common. We've demonstrated it in Australia. There's a publication coming out today in the MJA about reinfections, and that was between the sort of alpha variant and the delta variant. What we're seeing now with Omicron in South Africa is a really high rate of reinfection, and that reinfection is occurring less than 3 months after the previous infection. So people who are anti-vaccine, who feel that they will get complete immunity from natural infection, that is incorrect. The immunity is short-lived. And with that in mind, we are therefore concerned about people having exemptions from vaccination based on previous infection. That's the sort of natural consequence of where our concern goes. So while natural infection might improve temporarily that immunity, that in itself won't lead to the herd immunity. It will be the vaccination that does that. Yeah, just thoughts about mandatory vaccinations. There are some areas where we continue to think that it will always be important in certain workers. So certainly teachers, people in healthcare, disability, aged care, etc. They're just some examples, and certainly in custodial settings that are very high risk. There's probably some areas where mandatory vaccination is not required, and some of those considerations would be things like non-essential retail, where it's probably far less important because spread of infection in retail settings is just not the highest risk scenario. I suppose that those might be some of the things that would be looked at moving forward now that we've got to a much higher rate of vaccination. And then, yes, so when we get to that herd immunity, what happens to PPE? Really good question. And one thing that I do have to say is that it's been really hard to predict what are things going to be like when we get to a particular stage. And every time we've tried to predict, we've found that we've been mistaken, because this keeps having sort of throwing curveballs at us. So I guess, perhaps the best case scenario is that we move to surgical mask and then we move out of surgical mask altogether unless someone has symptoms. I'm not entirely sure that that's going to be the way that it transpires, but I think we can both watch that space together. With that in mind, if there's no other questions, Sarah, is that okay?
That is fantastic. Thank you so much for that,
No
Deb.
worries.
I think there's some fantastic and valuable information in there. And probably just a comment to make in regards to N95 masks and fit testing and fit checking. Do check in with your local PHN, because there is a number of them in Victoria that are supporting fit testing. And we do also have some resources and videos around fit checking that we can certainly share as part of the webinar this evening. So on behalf of the Infection Prevention Helpline, Deb, I'd like to thank you for your time this evening and all that great information that you have shared with us. And thank you for joining us. I know you do need to jump off, but thank you once again for your time this evening.
Thanks, Sarah. Bye, everyone.
Through a document that has been designed based on input from the Victorian primary care services. And I guess one of the things that we've had fed back to us since the helpline's been going, which started in June, was that around the fact that there is so many guidelines out there. They're changing very quickly. How do we keep up with it all? And so as a result of that, we've engaged with an expert reference panel, and we've actually come up and designed a document that we're hoping that's going to help you in some of this space. Now, the next few slides, I'm actually just going to talk you through how you can access what we're calling the risk matrix. This is housed on the APNA website, and it is protected, but only from the perspective that you will need to register, so that as the purpose of obviously the document we've created, guidelines are changing very quickly and on what seems like a daily basis on some weeks. It's so that we can make sure that you've always got the most up-to-date information. So you can see here there's a QR code, or there is actually a link to this risk matrix. But basically what it is in a nutshell is that it's a guideline that we have developed to help you implement based on the furloughing guidelines, ventilation guidelines, cleaning guidelines, etc. And we've incorporated it into one document whereby using a risk assessment, you can actually look at potentially what some of the procedures or activities that you're wanting to conduct in your organisations are. And then from that, you can look at, from a PPE perspective and some of these other things, what you need to consider through this process. Now, as I've already said, you will have to register for this. So the next couple of slides, I'm just going to take you through how to do that. You'll click on this link here, or you can scan the QR code if you're really quick at the moment. But of course, we are sharing all of this post webinar this evening. The next step is it will take you to a page that looks like this first part here. And you'll see there that there's going to be a buy now. Buy now in that you do not pay for this resource. It is a free resource. But given that it is open to members and non-members of APNA as part of the Infection Prevention Helpline, you just click on the Buy Now button. And it will then take you through a series of questions. And the purpose of that, like I've already mentioned, is so that we have your best contact details so that as the matrix are updated, that you will actually get that information and so that you can jump in and make sure that you're always using that most recent document. Once you have completed all of the registration information, you'll then be able to either scan this QR code or go to this link, and that will actually take you to where you can download the risk matrix, which will then be a page that looks something like this, and you'll see straight here that it says download the current risk rating matrix. And this, as you can see here, is based off the Victorian Health Guidelines, and given that, not only currently, but since August this year, we have been in what's called the black or peak risk rating. It really does alert all of your actions based on that COVID risk rating. And as I said, it's designed as an evidence-based guideline for overall care and maintaining business continuity. So once you've downloaded this document, it looks something like this. So you'll see up the top here, we talk around risk rating and give you, some pointers here, some guiding principles. And then we break down the activity into low risk, medium risk indoors, medium risk outdoors, high risk indoor, and high risk outdoors. And you can see there's definitions around all of these and what that means. This here is an example of one section. So we talk about staffing and environment, and we consider things here like vaccination status, if a person is unvaccinated or partially vaccinated, which obviously is highly unlikely moving forward, but staff that may be at high risk. So what are you considering with those staff or staff that can't be vaccinated? Have you got your QR codes? What's your workspace look like? And it actually breaks it down under each of these categories for you to consider this sort of stuff. This is another example. So we talk about different types of consults. So obviously, if you're using telehealth, we know that there is no risk associated there. But then, like Deb has mentioned already, utilising the furloughing document, you can see here we're talking about face-to-face consults less than 15 minutes, greater than 15 minutes, a procedure that might be lasting more than 30 minutes, and what the things are that you need to consider under each of those scenarios based on where you're doing this and the PPE that's being worn, etc. Another part of the document looks at other types of procedures. So here we've given examples of, and we've already had obviously a question this evening around cervical screening. But if you're doing sort of IUD insertions, if you're doing surgical excisions, or if you're doing ECGs, obviously we know that we are not conducting any respiratory function tests at all currently, particularly under that peak risk rating. Interestingly enough, that's a really big common question that we get through the helpline is, can I do spirometry? The answer is no. We are in a peak risk rating, and so you should not be doing any of those respiratory function procedures. CPR, obviously, CPR if it's needed, we need to do it, and there's guidelines around performing CPR during our peak. And then we go into things like DPR, MPs, health assessments, skin checks. And so the document, I believe, is 9 pages long, if my memory serves me right. It was 15 originally, and we've been able to condense that without losing any of the content. But certainly download it, have a look at it, and we are very much open to feedback. So through the Infection Prevention Helpline, we would love to hear your feedback. And as I said at the beginning, as different scenarios come into play, we will continue to add to this document. It is designed for the peak and active stage, so the black and red stage, which, you know, as Deb's really just pointed out, we're not going to be moving out of this for some time yet. And so it is designed to be that ongoing resource for you. Anything like you can see here with the respiratory function tests, or that's underlined as a reference, if you click on those links, you can access those appropriate documents to provide further information. And it's certainly not designed to be used in isolation. It is designed to be used with all of those IPC documents that Deb did mention and provided that link for as we move through this next phase of business as normal. So please jump in there. If you do have any challenges accessing the document, again, you can contact the IPC helpline, and we are certainly here to help you through any of those, hopefully not challenges, but any of those challenges that might occur. So there's just a question, why is this document not freely available at the front of the APNA COVID info page by a simple one check? So I think, like I've already answered to that, it is a document that we need to make sure that is up to date and that everyone is accessing the most recent document. This tonight is obviously the launch of this document. It's been worked on for about 8 weeks now, and I reckon we've probably changed it 20 times already, and that's not an understatement. Lisa might comment on saying it's probably more than that, given that she's done a lot of work on this. So we do need to, from a risk perspective, we need to make sure that everyone has that most recent document, and we need to be able to track who is accessing it. So like I say, unfortunately, that was probably the simplest way that we could do it. We will, and are happy to put a link on that front page. It is designed only for Victoria, and as you can appreciate, APNA supports nationwide. But the guidelines in there are only for Victoria. They are not applicable to any other state or territory. So we need to make sure that that's who's accessing it. So hopefully that's answered that question. But like I said, we are very much open to any feedback that you'd certainly like to provide as you start to use it. So what I might do now is I might actually request that all of our panel jump on and unmute themselves, turn their cameras on. So as I mentioned earlier, we have a large panel this evening to take us through some case studies and questions. So please pop your questions into the Q&A box, and we will address those as we go through. But sort of to start your thinking this evening, we thought we would start with a couple of case studies. So I've got joining me this evening Dr. Philip Webster, who is a GP in the Murray region. I have Margaret Jennings, who I'm sure is familiar to a lot of you, and Megan Reilly, who are the subject matter experts in infection prevention and control and support on a daily basis. We would certainly be lost without them. Any inquiries that we do get through the helpline. I have Lisa Sinkins, who is our project officer, of which all of you that have called the line, I'm sure are very familiar to her voice. And a wealth of knowledge. And then we have Janice, who I think is there. Is Janice there? There she is. Who is our illustrious leader from the Murray PHM perspective in regards to really pulling everything together from this infection prevention and control project. So what we're going to do is I'm going to walk you through a couple of case studies, and we're just going to get some input from each of our speakers here as we go through that. So our first case study this evening, we're talking about Dr. Claire. So Dr. Claire is working in a general practice. And as we know, currently the working days are long and the demands on current staffing is quite excessive and hard on some days. Dr. Claire has seen a patient this morning who has not disclosed that they were COVID-19 positive despite undergoing screening questions, and wants to know what actions she needs to take now. So I might start maybe with you, Megan, if that's okay. If we can approach it from an IPC perspective, in this scenario, what would be the things that we might need to consider, given that obviously this is an exposure to the practice, to the staff that are there, to the GP? If we take it from an overarching principle, so that higher level, what would we be suggesting to this practice that they need to think about straight up?
Yeah, thank you, Sarah. I suppose that my first comment would be around that we're living in a world of business continuity planning, where we're trying to maintain our services by putting in some risk mitigation strategies so that we can ensure the safety and the well-being of our healthcare workers, but also our patients or our clients. And a lot of those risk mitigation strategies should really be entrenched by now, or certainly being entrenched into the practice environment. And a lot of that has been around preparing for patient consultations and visits. And so we've been establishing ourselves in terms of, we assume now that all patients are going to be COVID positive, and I think that's probably a good risk mitigation strategy to put in place. And that we also are very aware that we're in that COVID peak black response, where at minimum we're wearing a surgical mask and eye protection. But we've put in those other strategies like our telehealth options, screening, temperature checks if that's appropriate, our waiting room signage, limiting the number of people that are coming into our practice and who might be accompanying that person. We put in some physical distancing strategies, and other things such as hand hygiene, respiratory hygiene, making sure that we've got appropriate PPE stock levels, looking at how we manage our shared patient equipment, environmental cleaning, and those sorts of strategies. So if we've got those entrenched, then when we do have a positive case that knowingly or unknowingly or belatedly we're informed about, then we've minimised our risk down. And I suppose our next step is that we then need to conduct a contact risk assessment, utilising the available tools. And that would be looking at items such as vaccination status of the healthcare workers, the PPE that the patient or the client was wearing at the time, but also what the healthcare worker was wearing, how far apart the patient was from the health worker, the person who was exposed, or other workers within that practice during the visit or the consultation, how long was that encounter, what procedures were actually carried out in terms of risk for transmission, and probably what the environmental factors are. So was the consult done within the practice or outside of the practice? If it was within the practice, what size of was the room? What ventilation strategies had actually been put in place in terms of air changes, external air coming in and getting rid of the stale air, and also what cleaning procedures are in place in terms of frequency and common touch surfaces. And then once we've actually been able to do that contact risk assessment, then we manage the situation based on the determined, whether it was a low, medium or high risk exposure scenario and the respective risk level evaluation outcome that we undertook. So whether it was that baseline risk, low risk, or was it actually a contact as such.
Excellent. Thanks for that, Megan. So Marg, in regards, Megan mentioned around ventilation. So obviously this is a general practice. I wondered if you would mind commenting on really the guidelines around ventilation in a general practice in this instance.
Well, thanks, Sarah. Generally, the guidelines might look a bit hospital-ish, but there are some really simple things we can do in general practice. And, you know, I do virtual walkthroughs, as you know, and some on site, and I'm always looking for open windows. And, you know, one of the simplest things we can do is if there is aircon, if there's aircon that supplies the whole building, and I'm talking about a standalone building, But if there's one aircon that supplies, you know, a roof-mounted system, I'd always be looking for where the intake is. And is the intake in a common, you know, high-risk area? You don't want that. You know, I'd be kind of saying, you know, let's do something about that. But I mean, the low-hanging fruit is open window, a split system per consulting area. You've got to have staff comfortable. You know, we're coming up to summer and it's hot in some areas already. But if you can isolate each room's air, that's gold. Some have popped in an exhaust fan to, you know, pull air in and pull air out. You know, some have managed to do that. It's time, air, distance. And I know people go on and on about 1.5 metres, but once you're in an enclosed space, the risk is going up. One thing that I would also add, and it's considered a breach, if the PPE is not being worn correctly, and I'm really tough about this, and that is that staff, you know, learn how to make, and I'm talking about a surgical mask. Of course, I drive a really hard bargain and insist on a P2 and a face shield when there's going to be that close contact for any length of time. That, you know, the mould with the surgical mask is really important, and that there's no crossing of the loops at the side, because air will find the path of least resistance. And here we are trying to breathe through that, you know, that middle layer of our 3-layer mask, the polypropylene layer. We want stuff to stick to that, and we don't want, you know, the shortcut that air going in or air going out takes. So where people are wearing just a surgical mask and a face shield, I really need to know that that's fitted properly. And of course, goes without saying that with the you know, the P2. So it will be considered a breach if Dr. Claire has not been wearing her surgical mask correctly. And she says, oh, but, you know, I had this on. I'd be digging a bit deeper and saying, well, how do you wear that mask? And did you remember to change it? Because once it gets wet, it's just not effective. So with the ventilation, it's generally considered, you know, 6 to 8 air changes an hour. Fabulous if you can get 6. And you want about a 30 to 40% refresh, you know, fresh air. So that looking at a split system with a window open, and I know we were all brought up to keep everything closed while we had the aircon on. Well, I'm here to tell you that's really not what we're doing, but we've got to stay comfortable and we need that air change. So that would be what I would add to that.
Lovely. Thanks for that, Mark. And maybe, Lisa, just if organisations don't know where to go to find this information out in regards to, you know, air exchanges, and who would they contact in their organisation? Or, you know, who would the practice manager, because I'm going to say this usually falls to a practice manager, but who could they contact to actually access information like this?
Well, they can contact us, obviously, but the PHNs and things like the air exchange, the building manager.
Excellent. Thank you. Yeah, and I think that is a question that we often get, isn't it? I don't know what the air exchange is in my practice. Who do I contact? I think, like Marg's mentioned, air conditioning. Hopefully, you know, you've had regular servicing of that aircon. So it is very much around contacting your techs. And Philip, I guess just from your perspective of a GP working in this environment, you know, you're exposed to this situation. Obviously, that would have a significant impact on your, you know, your team and your processes, and, you know, supporting that ongoing business continuity. Would you like to comment maybe on, you know, other things that it could impact on if this was the case?
Thanks, Sarah. Certainly, I mean, rural health workforce is thinly spread, whether we're talking doctors, nurses, allied health, and others who work at the primary health interface. We're thinly spread, so any loss of workforce is a crisis. I can tell you at the moment in our practice, we at maximum capacity had 13 and we're down now to 9, just having lost another doctor, and we're all feeling the pressure of that workload. So to lose potentially several staff due to a breach would be catastrophic. And so, you know, all of the strategies that Marg and others have mentioned, obviously we try to have in place, absolutely. It's interesting mentioning in this case up front, you know, the mitigation starts at the front line with the frontline staff who are taking phone calls from patients wanting to be booked in for appointments. And we had an interesting example of a potential breach the other day where a lady who was wanting to bring her mother into the clinic to attend the pathology collection room that's part of our building had said that she was not a close contact, but in further communication that she advised the staff member that her husband had passed away that day in hospital of COVID, and she didn't consider herself a close contact. So maybe we call that distress, or maybe we call it just or ignorance as to what it means to be a close contact. And so sometimes our best advice, even to our staff, when they're going through a protocol of questions, still can miss or can be misinterpreted by the patient. So.
That's a really good point. And I think, so I just got goosebumps when you said that. You know, it's the sad reality of what's happening at the moment too, isn't it? And like you say, we work in this, we're working in it every day. And I think you're right. I'm not sure that, you know, all the time that the general public understands those definitions that we're living and breathing, and very much so spot on. You know, this is a complete team approach. You know, our admin staff are feeling just as tired as what our clinical staff are feeling, and often taking more of the brunt because they're getting the calls and they're, you know, receiving at the front door, and, you know, they're almost those gatekeepers, you know, without actually asking to be doing that. And so it is challenging, and very much so, like you say, particularly in some of the smaller organisations, 1 or 2 staff is a massive impact. And so it is really considering, how do we make sure that we have all these principles in place and mitigate that risk. And I've noticed there's a really lovely comment from Catherine in the chat in regards to thanking us for the work that's been done on the risk matrix, and, you know, understand the work that's gone into it. And thank you, Catherine, for saying that, you know, APNA has been a godsend when it comes to this information, having information that you can trust and rely. And that's certainly the purpose of this helpline, is to provide that and try and help ease some of that pressure for you on a daily basis. So thank you everyone for your input in there. I'm going to save Janice until the next case study, but you'll also see there on your screen, that, as I've already mentioned, that we've been in the peak risk rating set since, I'll get my words out in a minute, since the 23rd of August this year. So it's not something new. And I think we have had some confusion between, as things start to change, you know, in the general public, and as restrictions start to ease, what does that mean for primary care and for health? It's increasing our risk, as really this case study here does show. And so we really do need to be vigilant in regards to that. There's some examples of some of the things we've just spoken about around what you should be considering. And for those of you that may not be aware, there is now a GP priority phone line for GPs that are managing COVID-19 exposures. So please jot down that number. Again, it's like all services, it has limited capacity, but certainly that helpline has been a response from the department in regards to, you know, the high needs that we are seeing. So please make sure that you have that number on hand. And like I say, we are happy to help where we can. So we might move on to the next case study now. And in this case study, I'm actually going to start with Janice. So here we have a case study of Dr. Simon, who has been asked to do a home visit, or, as we're saying, manage a COVID positive patient in your practice. So this is where we want to talk a little bit around the COVID-19 care pathways. So this is not a regular patient of this GP, nor has Dr. Simon actually, you know, worked in this space before. And so what he's wanting to know are, what are some of the processes he needs to consider in order to keep him safe, as well as obviously his family and his co-workers. So just to get us started on this case study, I'm actually going to throw to you, Janice, and maybe ask if you could give us a little bit of an update, or for those that aren't aware, around the COVID-19 pathways, under health pathways, and just sort of give us a bit of a brief and a background around those.
Yes, thanks, Sarah. So I think with most PHNs, or all PHNs, been working with their local health services in order to share the care of virtual home monitoring for patients in the home. But that's actually to monitor them virtually. So there's been a lot of work to develop those pathways and to transition the patient from the acute health sector to the primary care sector. And the risk is all around, risk is determined on the risk of deterioration. So which is a mixture of comorbidities, social conditions, chronic conditions, etc., as well as the disease severity. And that's how they determine which service actually supports the monitoring of that patient. And they're monitored for that 14-day period of isolation, although I think that's just recently reduced. But the Department of Health, the Commonwealth Department of Health, has recently funded PHNs to support face-to-face home monitoring in the person's home. So, and that's from the primary care sector. Now, they've done this in recognition that there's been a cohort of people who have been found to be positive with COVID, who actually don't respond very well to the Western virtual home monitoring model that there is. So often they're underserviced, don't have low connectivity, don't have the funds to actually monitor themselves, or don't know how to monitor themselves. Health literacy is poor. So we're targeting this area. We're working with our local general practices and community health services to actually set up a home monitoring service for a particular cohort of patients. So most people have heard of health pathways, and the majority of primary health networks have health pathways. And health pathways are developed with subject matter experts written by GPs for GPs, but they're also used by many other health disciplines. And that's where all the up-to-date information on anything related to COVID is put into the health pathway. They're updated every day. And as soon as something new comes into play, they're updated overnight. And there's a really a national approach to updating those pathways. So being really prepared, and we know with our metropolitan partners, Northwest Melbourne PHN, they used health pathways with a lot of their outbreaks, and they really drove the general practices to review the pathways at the beginning. But in this instance, keeping that general practitioner or their staff, practice nurse, etc., safe is the absolute priority in the first instance. So doing those pre-checks, having those pre-checks in place, which includes having the PPE, the equipment that you need, doing the home risk assessment, knowing how many people that are in the household, how many people are positive, were they actually living within the house, or are they beside a window? All of those things are quite clear that need to be done. So we're working also closely with Margaret Jennings, who's also helping us develop the process and for all of the home risk assessment. And we are developing an education package for those general practices that are participating in the home visit model. So there's quite a lot of work to do to make sure everyone is safe.
Excellent. Thank you, Janice. And Stephanie's made a statement in the chat, and I think this really does, which is why I'd left it till now, but she was saying that it was a big ask to expect a very unwell patient to have to send texts and make phone calls when they're acutely ill at home, but not sick enough for hospitalisation. And I'm not sure if you want to comment on that, Janice, but that is the intent of some of these services, is to support those scenarios.
Yes, absolutely correct, because we know that's the case. Some people live by themselves, some people don't, but still don't have this sort of support. And even having the phone, to actually be able to pick up the phone and answer the phone as well as send those messages, which is I didn't know that was the case until tonight. So again, that's a big issue, and we might even need to add that to our eligibility, or thinking about our eligibility criteria as well.
Excellent, fantastic. Thank you so much for that, Janice. That was really valuable. And I'm just wondering if maybe some of the panel might like to comment on some of the things that this GP would need to consider before, going out on one of these home visits. So Megan, did you want to maybe comment from maybe a PPE perspective around some of the things that the GP should consider?
So certainly being prepared, because obviously PPE has to be, appropriate PPE has to be donned before seeing the patient. So that means back in the practice, I suppose, how you're going to put your PPE kit together to maintain that until you get to the patient's home. And the level of PPE, because we know that this person is positive, so it will obviously be complete or full PPE, which will include the N95 respirator. But some of the things to consider would be the most appropriate location to don and doff PPE. I've been working with some community organisations just recently, and we've been talking very much about initial environmental risk assessments to be actually able to determine where we can safely don and doff PPE, but also very aware of the privacy and the confidentiality of that individual within that home. And I would suggest that out the front of the house, donning your PPE is probably not terribly beneficial for anyone. But the other thing to consider too is that once that PPE is safely removed, how is it going to be disposed? Do we have the resources to be able to confine and contain that waste, and then to be able to transport it back to the practice where it needs to be disposed of as clinical waste? So that's, I suppose, the things to be thinking around in terms of personal protective equipment. And also the other thing is the patient that Dr. Simon is going to be visiting and consulting actually have a surgical mask that they can put on prior to walking through the front door.
Excellent. Thanks for that, Megan. So Marg, would you be able to comment for us on regards to maybe where or what are the opportunities around where we actually see this patient if we're going out on a home visit?
Okay, well, I would try and chat to them through their bedroom window. I would actually want some assessment of where are they in the house? Are they out of bed? Have they been able to wander? Like, I guess Philip would be the same. You'd want to be able to get a sense when you arrived of, is the person going to come to the front door? That's a really good sign. Or, oh no, their partner or family, no, they're in bed and they're asleep. Oh, okay, you know what I mean? So I would try to get a sense before I even went in. And it could be that the person's chirpy as, sitting up in bed, and they're happy to talk to me through their bedroom window, and I can get quite a bit of information that way. At some point I will want to go in, but who knows, maybe I'm getting enough information there. But I think we probably want to check the oxygen and stuff like that. So I'd actually do a fair bit of work. I wouldn't get out of my car and put my full PPE on, as Megan said, and rat-a-tat-tat on the front door. So I'd get as much info as I could, and then I'd make that decision. I'd be sort of casing the garden a bit, Megan, and looking to see if I could get behind a shed or something and put this stuff on, and maybe coming through the back door. But it's all going to be so site, dependent. But I think getting a sense of where the person is in the house, and would they in fact like to come out to the front veranda where, I could get away with a mask on. And that's sort of, that's not looking too bad. They might be in their pajamas, but they're feeling it, they're happy to walk around. So I'm always looking for the least risky scenario. But if they're able to come outside, then I'm probably not going to put on full clobber, but I'm at least going to be putting on, my face, and be doing, lots and lots and lots of hand rub, and of course keeping my distance. But once I've got to get in close, whether I'm inside or outside, it is going to have to be, everything, because I'm bending over and I'm making that sort of contact with the person. So yes, it's really just going to be, almost site dependent and patient dependent. Also, if I'm going to go into the patient's room, I really want the window open. And not the whole family around, because they're probably, half of them are infected as well, So I'm trying to really make this room a little bit risk reduced. So,
Excellent.
yeah, that's what I'd be doing.
Thank you. And I think what I'm hearing both yourself and Megan say is it is all about preparation. It's all around, getting as much information as possible beforehand and ensuring that you've done that proper risk assessment based on, what you're facing. So I guess from that perspective, Philip, when we think about it from a general practice, starting to manage these types of patients, we've already heard tonight what the modelling, is telling us, and case numbers, and we know that management of COVID positive patients is something that we're doing in primary care and is likely to increase. So from your practice's perspective, whether it be your own patients or, patients that wouldn't ordinarily come to you, what would be some of the things that you might need to consider in order to implement this sort of model?
Thanks, Sarah. And I have to admit that at this stage in the process, our practice, while expressing willingness to be involved in managing patients in the home, the case numbers haven't been sufficient in our area to require that. But looking at the numbers that Deb was talking about earlier, projected for next year, then I'm sure that is going to be the case, that we will be required to. And apart from the observations of Margaret and Janice already, and Megan, I guess my clinical impression of the patient is, in the first instance, guided by what the patient says. So, listening to the story is significant, but frequently I find, and it's true, particularly respiratory symptoms in patients, that they underestimate their capacity because they're sitting or lying in bed, resting, or they're sitting in a chair, not being active. Even having their oximetry measured when they're resting may be misleading, because as soon as they try to do anything, if they've got significant respiratory reduced capacity, then they'll be breathless and their oximetry will drop, and we see that in the clinic setting. So I guess there is value in looking at the patient and talking to them and seeing how they're feeling, but we at some point need to have an idea of their functional capacity, not just their resting capacity. In terms of GPs too, I think like all of our community, we've been swamped by the fear factor of COVID over the last 2 years. And so there is some resistance to not only in our clinical practice of our building, trying to keep positive patients out, but then putting ourselves out into the community in a position of risk is something that there's a huge degree of reticence. So not all practices in town, I know this is something we've canvassed already, not all practices and practitioners in town are willing to put themselves in that position. So the load will fall on the willing, but hopefully the numbers will not be insurmountable. So.
Excellent. Thank you for that, Philip. Appreciate that.
Sarah, could I just jump in just after what Philip said? Philip, I didn't perhaps make myself clear, but what I was imagining was that I do as much as I can outside so that I actually spend less time inside. So I wasn't sort of saying hello at the window and goodbye, but it's, that sort of drives home that point about time spent inside. So I can get a certain amount of information outside and then I go inside because I've got to be close and do that examination. We all know about the happy hypoxics.
I heard what you said, Margaret, and I think it's excellent advice, and certainly as a clinician, I would utilise that same strategy. So yes, definitely thumbs up, that's great.
Excellent. Thank you for that, guys. What I'm going to do now is I'm just going to jump through a couple of resources, and then if I can keep you all on camera, we're going to go to some of the Q&As that we've got come through. So based on what Janice has shared with us in regards to health pathways this evening, there is some links there that we will be sharing, obviously, when you get your presentation. So please have a look at your local health pathways, as well as the RACGP has released a fantastic guide on COVID-19 home care guidelines. So if you haven't actually looked at that resource yet, that is by far your homework to go and have a look at that with the healthcare pathways. RACGP also has a huge amount of resources around supporting the management of COVID-19, supporting teams, our infection prevention and control standards, and those sorts of things. So please have a look at these links when we send them out. What I'm going to do now is I'm actually going to jump to some of the Q&As that we've got that have come through. So one of the first questions that we've had is, what are included in a deep clean process in a GP clinic? So we do know that as of Monday afternoon, the cleaning guidelines from the Department of Health were updated and re-released. And so who'd like to take this one? What's included in a deep clean process in general practice clinics? And I'm just going to add to that, when do we do a deep clean? Because I think there is still some confusion around what is considered high touch surfaces and how frequently we clean those versus when do we do a deep clean. Who'd like to jump in? Megan, you're unmuted. So does that mean that I'm going to jump to you?
Well, I'd probably just like to make a comment in terms of this would be in relation to an exposure, and conducting that risk assessment is going to be really important, because a deep clean, in fact, may not actually be required of high touch surfaces that have been contacted by the infected case, if they already have a good program in place in terms of cleaning. So the minimum is to be cleaning twice daily as part of the regular cleaning schedule. And of course, we clean after each case consultation as well. And whether we would need to do a deep clean would be depending also on the time since the actual exposure. So the need to even close if a deep clean was required will really be dependent on the function and the layout of the practice, the case movement, and the location within the practice if they were indeed inside. I'd just like to make that comment first.
Yeah, fantastic. Thanks for that. And I guess, Margaret, I'm going to ask you, who can do a deep clean? Because I know this is a question that we get frequently through the helpline. You know, who does my deep clean? Do I pay the thousands of dollars that, you know?
Well, let's avoid paying $6,500, but it requires some thought. So anybody, if you like, but I would want somebody who works in the practice. I would, if it's 72 hours that's elapsed, fabulous. I always say that's great news that it was 3 days ago. A little bit naughty to say that, but we know that really there's very little replicable virus around. In fact, you can probably see that we've gone away a bit from cleaning in public spaces. When I say gone away from it, we do it a bit. But, you know, you don't sort of see the traffic light buttons being done, you know, twice a day like we used to. So we've actually learned a bit about contact transmission, and it's really not that high, but it is in the healthcare area, especially in, you know, a place like ICU where buttons are being pressed with gloves on, and for some reason that surface, you know, the keypad doesn't get cleaned and somebody else comes along, and I don't know why, but their fingers find their way to their mouth. So we're getting a bit more evidence around that, just as we got some more evidence on, you know, airborne transmission. So the deep clean itself is really in two parts, and to make it short, it's always high to low and clean to dirty. You know, that's the way you sort of do it. But it's really the clean first, and then, you know, obviously you've got your gear on. But very few people would actually begin to do it as soon as the suspect is gone. It's really interesting. People will go, but they're suspect, but we don't know. So we'll wait for the result to come back, which is 24 hours. And then they're sort of like that. Should we close the clinic? And of course, I always say, get in early and do all the preventatives so that you're not even in this position. You know that I'm big on that, and that we don't use a waiting room, and that people go through, it's only transient passing, you know, into a room. And so the second part of the deep clean is, in fact, the correct application of the correct, you know, disinfectant. Stay away from bleach, please, but about a 0.4%, you know, what's the stuff in Pinoclean? A benzalkonium chloride. And we know that even 1 wet minute on a surface will give you a 4 log reduction. Not bad. I know the manufacturers say a few minutes, but basically leave the surface wet. That's not bad. And as Megan said, let's just hope and assume and pray that the staff are doing it twice daily. They can use the 2-in-1 step of all the high touch common surfaces. So I think it would take probably, if you were going to do all the rooms, tea room included, because people could not decide what to do, I would say it would take 2 staff 2 hours to do. And you've just got to close the clinic.
Excellent. Thanks for that, Marg. I'm going to throw the next question to you, Janice, in hope that you can actually respond to this. But we've got a question around, where does the New South Wales Victoria border town sit using the matrix? So New South Wales side, but under Vic Health.
So Albury is part of the Victorian health system. I know that's confusing, but they are part of the Victorian health state government's response. So in the rest of our rest of the regions in Victoria that are bordering would be need to respond to New South Wales. It is quite confusing, and that's relating to the look. It is a tricky question, but certainly our matrix for our Albury counterparts would be okay to use because they're part of the Vic State Health Department. In regards to other parts, such as, so if you're, and this is an example, because we have an office in Albury, they haven't had to wear masks in the office for many months, whereas and that's a different set of rules as opposed to the health setting in Albury, if that makes sense. I know it's a tricky question. That's how we've been applying it.
Excellent. And I guess to probably add to that, if people are unsure, we're happy for them to contact us. And then if it's, if it's not within the realms, well, then certainly, we have provided support to people on those border, whether it, be in the form of where to go from a New South Wales perspective. So please, we'd rather you make contact than wonder where you sit, and we can certainly help with that. I'm very aware of the time. There's a couple of questions left. I think that we've had a question around the deep clean guidelines. Yes, we will provide those as part of the post webinar resources, as well as if you jump in this evening and you download your risk matrix, the links are in there under deep cleaning. You can click on that section and it will take you to the latest resources. So that will provide all of that for you. Just a couple of comments left. One of them is, with home visits, a team seems better to check don and doffing PPE ? Well, obviously it's fantastic. We like to have what we call spotters from the perspective of PPE. So, if you've got a team, we have had some questions around, I'm working by myself or we're a small rural clinic, how can we ensure that our PPE is being donned and doffed correctly? I think, as I mentioned earlier in this evening, we have a number of videos on the website that you can access around donning and doffing. And it's a little bit, I guess it's about being a little bit ingenious in that we have used Skype and other Zoom, all those sorts of platforms to actually, have people check PPE. So we're not like the large hospitals where obviously we've got teams and spotters that can jump in and out, but actually just thinking about other ways that you can engage either your team or, a close by practice, or using that technology to do that. So certainly we're happy to support some ideas around that if you're unsure, and lead you, direct you to where all of those resources are as well. The last one that we're going to tackle this evening is, I'm a little unsure of this, but it says, if VOC enter, ought we have guidelines for tent triage outside clinics? I'm guessing that's a question around, do we need specific guidelines for when we're doing triage outside? I'm not sure who's actually popped that in there. It's an anonymous question. So I guess we have got some guidelines around this, and certainly the risk matrix, we do talk around different procedures, different procedures, or activities that you may be conducting inside or outside. And so from that perspective, it's designed to help you with that decision making and that risk assessment based on what you're doing and who you're actually seeing. So I'm hoping that's provided a little bit of context around that question. Certainly, if I've missed the point there, please feel free to contact the helpline, and certainly we can help provide you with some resources around that. So for now, I'm actually just going to say thank you so much to our panel. I'm not sure if anyone had any closing comment that they wanted to make, but where to from here? I just want to point you to a resource in regards to, we've spoken a lot tonight in regards to, risk assessments and, the things that we need to consider. Bearing in mind, and just remember your hierarchy of controls when we talk about infection prevention and control, and that our most effective measures are those where we're eliminating the risk. Our least effective, believe it or not, is PPE. And we need to consider all components in this hierarchy. Certainly, we've got some examples of what sits under each of those there, but this is a really great visual that you can think about when you're doing your risk assessment in your practices or your organisations, and think about how can I actually consider these sorts of things to reduce risk. So please have a look at that one when we come out, when the webinar resources come out. In regards to your 6 principles of COVID-safe workplaces and your business continuity, these are our top 6. So think about your physical distancing and make sure that you're practicing that, wearing your face masks, practicing really good hand hygiene, making sure that you don't have those blobs on your hand sanitizer, that they're actually being cleaned as well as part of your high-touch cleaning surfaces. Making sure that you've got your electronic records in place and that you can act quickly in the event that, you have an unfortunate situation where you do need to close, which hopefully is not, it's not the way we're heading anymore. With our risk assessments in place, you need to make sure that you're avoiding as many interactions as possible in those enclosed spaces. So considering your ventilation and all the other things that we've spoken about this evening. And I think as Philip, articulated really, really well, losing 1 or 2 staff members can have a huge impact on practices. So think about creating some workforce bubbles. Do you have a couple of different teams so that, in the unfortunate situation that you have an exposure and they may need to furlough for a period of time based on your risk, you can still keep that business continuity happening. And so, think about these 6 principles. And if nothing else from tonight, you go away, think about those and do an assessment on those in your practices. We are here to help you. So if you come up with some gaps, that's not a problem. Please reach out to us at the helpline, and we will certainly more than willing to provide any support that we can. So thank you for joining us this evening. The QR code there for your evaluation to be completed would be really appreciated. I think Lisa's going to pop the link also into the chat now. If you could jump on and just do those. Tonight's webinar and its topic has come out of feedback from previous webinars. And so we really do appreciate that feedback and take that on board, making sure that we're providing you with the most up-to-date information and appropriate information that you are needing as, what seems like on a daily basis, some weeks things are changing. A little bit of a plug again. I know I've mentioned the helpline a number of times this evening, but again, we are here to help you. And it's not just COVID. If you've got a question around sterilisation, around wound management, processes, accreditation, all of those things in general, we're here to help you. And so please reach out either through the contact us form on the website. You can book an appointment through the website, or you can ring us on either of those numbers, and we will be back in touch, whether you be a general practice, a community pharmacy, or an Aboriginal controlled community health organisation. We're here to help, and as I've already mentioned this evening, we're very honoured and lucky to have both Mark Jennings and Megan Reilly support the helpline in conjunction with Murray PHN. So I think I've got 1 minute left. I would like to thank our presenters and our panel tonight for a fantastic evening and some amazing information. We will share the slides and the recording with all registrants. But other than that, thank you to everyone. Have a great night, and we look forward to hearing from you soon. Thank you.